This is the Race as a Social Construct lecture, this second lecture in the second portion of the course. We have continuously asked this question throughout the beginning of this course. Does race exist? In fact, one of the articles that you read for the first section of the course by Baumschad and Olson, written in 2003, was titled, Does Race Exist? You are going to read an article this week by Gravely that also addresses this question. Gravely argues that this question seemed to have an agreed upon answer in the world of anthropologists, and that answer is no. However, recently there's been a renewed debate over this question, and he lists a number of journal articles that are focused on addressing the question of whether races exist. What is the biggest issue with the question? Well, I hope that most of us would agree that the question can be interpreted in many different ways. For example, does race exist biologically? Is there a natural biological difference between humans? On the other side of the coin is interpreting this question in a social direction. Does race exist as a socio-cultural reality? I think most of us would answer that yes, it does. What I want to do in this lecture is address how race exists as a socio-cultural construct, but also investigate how the socio-cultural reality of race has biological consequences or biological impacts on individuals. Before we get into this, we need to start with some definitions. We have used all three of these words so far this semester, but we haven't really defined each of them or discussed how they differ from one another. Race is generally used as a term that refers to groupings among people that are understood as having some type of physical basis. I'm not saying they do have a physical basis, but the term is used in this way. For this reason, the term is often used interchangeably with another term, ancestry. Race is not supposed to be viewed or interpreted as being scientific or having any sort of scientific basis, but often it does. So keep in mind that race is a worldview. It is something that's culturally constructed. It's a way of interpreting or defining differences. Ancestry is a line of descent. So ancestry refers to a person's origin of descent, their heritage, or the place of birth for a person. So you can see how the two terms, ancestry and race, are often used interchangeably. Ethnicity is a term that refers to groupings among people based on cultural differences, things like language, religion, customs. Ethnicity can also get blurred with the term ancestry or race because people that share a common culture or a common ethnicity are usually more apt to marry each other and produce similar ancestry lines. Also, in the history of anthropology, we know that these two concepts, ethnicity and ancestry, have been blurred simply because discussions of race always include cultural differences. Race is a social construct, but it has physical and cultural implications. We're going to discuss the differences socially between what we define as races, but because it is socially defined, there are patterns that are seen as group boundaries. So here in the US, there's this idea that humans can be divided into groups that are relatively homogeneous. Typically, this is done based upon 4 or 5 groupings. These are viewed as non-overlapping, distinct groupings that are associated with everyone. You are one or you are the other. There's also a cultural implication to race being socially constructed. Oftentimes, the physical differences that we associate with race are also associated with the reasoning or the causes of having cultural differences. In other words, your skin color is going to denote or be associated with the type of cultural practices that you partake in. And because of our history in the U.S., there is also a cultural reality that races are ranked and that some races are seen as superior to others. Racial attitudes, racial groupings are continuously shifting. For instance, groupings have historically been affected by the Great Depression. World War II brought about a change due to need for workers in factories. Many manufacturing jobs were open to Black individuals that weren't before available. There's also been periods of time in the growth of education, the presence of new immigrants, internal migrations, people moving from the South to the North or vice versa. All of these changes have contributed to group definitions and these boundaries that we've created of grouping. These groupings change and shift throughout time. Even though these boundaries of race have changed throughout history, racial boundaries are always socially defined. I think that becomes most apparent in the U.S. due to the historical accounts of, quote, Black versus white. I think we can all agree that there is a prevalent, strong boundary here in the U.S. around Black versus white versus others. For instance, there are white people that have dark skin that will get upset if they're called Black, or vice versa. There's many Black individuals with light-colored skin that get offended if they are called white. For instance, there's a term called passing that refers to a light-skinned Black person kind of pretending to be white. This strong boundary is socially defined, and other countries may not necessarily have these same rules or these same systems. I think the best example that reflects these social boundaries that I'm discussing is the election of President Barack Obama. Before he was elected president in 2008, everything about him, everything about his history sort of contradicts what most Americans believe about race. His name, for instance, reflects this. He has a genuine African name that's not been invented or changed. And historically, we know that many Blacks have done this, have changed their names here in America. So he wasn't raised in a family that was impacted by slavery. And for that reason, he probably wasn't taught much about the heritage of slavery and racism here in America. What's most interesting about his history is that he is the product of one of the strongest and oldest taboos in America's society, that of interracial marriage, especially the marriage of a white woman to a Black man, which is the case of Barack Obama's parents. This became a talked about thing when he was elected. The public acknowledgement of the different, quote, races of his parents have been brought into the media over and over again. Most media have used this as a way to question his identity. What is his race? Is he really Black? Is he biracial? These questions are really reflecting what I mentioned earlier, in that boundary lines are always changing. The big question that was really being raised by these journalists is, what is his election? What does it ultimately mean for race relations in America? I hope we can all agree that the fact that Obama received 43% of the white vote is some sort of indicator, I hope, that positive change in America towards attitudes about race and these very strong boundary lines that we put on them are changing. Let's Let's talk about the U.S. Census. I think this is also another example of how racial boundaries have changed through time. In the year 2000, a major change took place in the census, and there was an option added to the race or ethnicity category that actually allowed individuals to check multiple boxes. One of them being a box that says some other race. Before then, individuals were only allowed to check one box. There's also a discussion now of Hispanic being offered in the 2020 census as an option for question number 9, what is a person's race? When before, Hispanic in the U.S. Census was primarily defined as an ethnicity. So it's these types of changes in the census that are really reflecting boundary shifts. Whether those are related to social differences or differences in ethnicity differs. As we've discussed, race is certainly a socially constructed idea, but what I want to focus on for the remainder of the lecture is how the social constructions of race become biologically significant. There's clear evidence that racial health inequalities exist, and that these inequalities are consequences of race-based social inequalities rather than biological differences. In the U.S., African Americans, American Indians, and Pacific Islanders face some of the most pervasive disparities compared to white Americans and some Asian Americans. Data has shown, for instance, that African Americans live 6 to 10 years fewer than whites. For an example, an analysis of mortality data from 1991 to the year 2000 showed that if mortality rates of African Americans had been equivalent to those of whites, then more than 880,000 deaths would have been avoided. These epidemiological differences span the entire life course and can be seen in birth outcomes and reproductive health. Some of these inequalities are growing. For example, between 1980 and 2000, the black-white ratio of infant mortality increased 25%. This occurred even when the overall infant mortality rate was declining. African American infants are 3 times more likely to have a low birth weight than white infants. This figure shows infant mortality rates are higher among African Americans and Native Americans than other racial groups. Even if you compare mothers of similar education levels, these differences still exist. Infant mortality rates decline as the mother's educational level increases. But this is across the board for all races. For instance, take a look at this figure. You can see that African American women with a college level degree have higher infant mortality rates than white women with less than a high school education. So education doesn't even erase this racial gap that's present in infant mortality. There are also differences in reproductive health. African American women are 4 times more likely to die in childbirth than white women. What do you think this is related to? Well, this difference is likely related to the fact that black women lack access to prenatal care that's essential for a healthy labor and healthy delivery. African American women also show a higher prevalence for HIV at a rate of 24 times that of white women. Latinas are diagnosed with AIDS at 4 times the rate of white women. So, what are the causes of racial and ethnic health disparities? What can they be attributed to? Well, in Western culture, and this is something that Gravely discusses in his article that you're going to read for the weak. There's an accepted ideology that racial health disparities are natural. In other words, the disparities are genetic or biological differences that exist between racial groups. Gravely refers to this as racial genetic determinism. A good example of this is the prevalence of hypertension. There's a 50% higher rate of hypertension among African Americans relative to white Americans. And for a long time, health professions attributed to the forced migration of African slaves in the 17th and 18th centuries. This is commonly referred to as the salt slavery hypothesis. It's this argument that Africans that survived the deadly trip from Africa to the New World were the individuals that could hold more salt in their bodies, making it an advantageous trait. So the hypothesis argues that rates of hypertension are higher in African Americans because they are descendants of people who could retain sodium. In other words, this is an example of this worldview that Western cultures have, that the health disparities we see are in the genes. They are biologically determined. However, this hypothesis, among many others, has been disproven in recent years. In 2005, Cooper and colleagues showed that hypertension rates varied considerably within racial groupings, depending on geography. As you can see from this figure, European nations show the highest rates of hypertension, whereas some of the lowest rates of hypertension are found in West Africa. But African-descended Americans show a rate 3 times higher than the rates found in West African individuals. So this provides a really good example of how many arguments of some of the health disparities being associated with genetic or biological differences aren't always factual when you actually analyze the data. So then what are the causes of racial health disparities? If it's not genetic or biological differences between racial groupings, then what can we attribute it to? I think the answer to this question is that the causes of health disparities are multifactorial. In other words, there are several factors that sort of influence one another, but they all play a role in creating these racial differences in health. The most influential one is a socio-economic inequality. In general, people of higher socio-economic status have better health than those of a lower economic status. This is directly related to access to health care. Another factor that influences difference in health behaviors. I put culture in parentheses here simply because this is essentially referring to differences in culture. What I mean by this is that is the data that shows that some racial groupings report being less physically active than others. Often related to this is what is referred to as residential segregation. Health behaviors, being active or not, can be shaped by neighborhood context where individuals live. This can have major impacts on health resources and life opportunities. So what I've done to discuss this is to think about them as 3 major causes. 1 being healthcare access or unequal treatment. 2, social determinants. And 3, race-based discrimination or prejudice. So I want to briefly discuss the evidence for each of these causes. Most data that is available for this first cause comes from the National Healthcare Disparities Report, which is released annually by the U.S. Agency for Healthcare Research and Quality. The most significant factor that's contributed to inequalities in healthcare is health insurance coverage. Now, most of the data we're going to discuss is not the most recent, and with Obama's administration, we now know that access to healthcare has changed quite a bit. However, this is still a factor that's going to contribute to disparities for a long time. These are just some facts that were taken from the NHDR. More than 11 million immigrants were uninsured in 2003. 21% of white Americans were uninsured at any point in 2002, while 28% of African Americans were uninsured. 44% of Hispanic Americans. And you can see from this figure here some results from the 2015 report that showed that 45% of whites were uninsured and 55% of other, or what they are referring to as people of color, were uninsured in the year 2015. Some other factors that contribute to healthcare access are having a regular source of healthcare. This means that an individual has access to a local physician or clinic. Research shows that the underinsured and uninsured and many racial minorities report that they don't have a regular source of care. Oftentimes, this is related to and or contributes to another factor, language barriers. There are over 46 million people in the U.S. that speak a language other than English. Individuals that are less proficient in the English language are going to be less likely to have a regular source of care. Aspects of the clinical encounter also have been shown to play a role in contributing to healthcare inequality. This is referring to the interaction among patients with their provider. Research has shown that implicit biases, often unconscious biases, influences doctors' decision-making and treatment of patients. An example would be the stereotyping of certain minority groups or racial groups, like presuming that they are more likely to abuse drugs or alcohol or be less educated. The neighborhood and community context, the places where people live, has also been shown to affect their access to healthcare and resources. Historically, the U.S. has had high levels of residential segregation based upon race, ethnicity, and income. As an example, in 1960, lower-income African Americans were 3.8 times more likely than low-income white families to live in a high-poverty neighborhood. This has increased dramatically in the year 2000, with African Americans being 7.3 times more likely than whites to live in a high-poverty neighborhood. You can also see in this figure that this trend is the same for Hispanic families. Residential segregation fuels other factors as well. This kind of goes back to this multifactorial example, such that these neighborhoods are home to poor public education, an increase in toxic living conditions. They tend to have higher rates of crime and incarceration. Also, there are higher instances of crowding, elevated exposure to allergens like lead and dust mites. Local markets are lacking in availability of nutritious foods, which is directly related to health habits and health care. So you can see that this factor alone has kind of a domino effect to other factors that all contribute to healthcare inequality. The last factor that I want to discuss is race-based discrimination. There's been a lot of research that shows the health-related impacts of discrimination in minority groups. For example, research has shown that Black women who were victims of racial discrimination were 31% more likely to develop breast cancer than those who did not. Repeated race-based discrimination has also been shown to be associated with higher blood pressure and diagnosis of hypertension. This list of research could, of course, go on and on. So as I stated in the beginning of the lecture, race is a social construct, but it has clear biological consequences. Inequality in health is the direct result of structural racism. It creates unequal distributions of resources among groups. And this is a direct reflection of what we discussed in the first lecture of the semester. In order to understand human variation, we must look at this triad, that environment affects culture, culture affects biology, biology affects environment. Each of these things are working together and has a big impact on human variation, whether that's socially or biologically. But the social aspects of race are always going to have biological effects.